the inside story on the issues that affect you and your community. This is Local 12 Newsmakers.
You've all heard me say this before. Moving from an opposition party to a governing party comes with growing pains. And, well, we're feeling those growing pains today. We came really close today, but we came up short. I spoke to the president just a little while ago, and I told him that the best thing I think to do is to pull this bill, and he agreed with that decision. I will not sugarcoat this. This is a disappointing day for us.
Good morning and welcome to Local 12 Newsmakers. I'm Dan Hurley. 10 days ago, the long-promised Republican commitment to repeal the Affordable Care Act, Obamacare, and replace it with the American Health Care Act stalled because of the inability of the Republican Party to find a proposal acceptable to all factions of the party. This is not the end of the effort, only a pause. For the last 2 weeks, regular viewers know that I have tried to focus on the implications of federal health policy existing and proposed on local care institutions and people. 2 weeks ago, I was joined by the Government Affairs Director of Mercy Health, last week by representatives of the Charitable Pharmacy of St. Vincent de Paul and the leaders of the Good Samaritan Health Clinic in Price Hill, both of which care at no cost for people who are not covered by any plan and cannot afford health care. I am joined this morning by two leaders at the center of the local health care ecosystem. Dr. Richard Lofgren is a board-certified internal medicine physician who has been in healthcare administration for 25 years. Dr. Lofgren assumed the presidency of UC Health in 2013. And Craig Brammer is the CEO of the Health Collaborative, a partnership of companies and organizations across the region committed to what they refer to as the triple aim: healthier people, better care, smarter spending. Before assuming his role at the Health Collaborative at the end of 2012, Mr. Brammer worked at the Office of National Coordinator for Health Information Technology in Washington, D.C. Both of you, welcome to Newsmakers. It's good to have you here. So let's begin, Dr. Lofgren, with sort of what you see how has the the Affordable Care Act, the ACA, Obamacare, how has it impacted that you can observe the patients that you care for? And let's set it up that way. What difference is this act that we've been living with for the last 7 years? What difference has it made for you?
Well, there are several components to the Obamacare or the ACA Act that has impacted, but the one that's probably most tangible has been the expansion of Medicaid, which, as you know, the governor has taken a real lead in that and really has had a tremendous impact throughout all of Ohio. Over 700,000 people have now gained insurance that didn't have it before. And so there's no question that it's had a tangible and palpable impact on expanding coverage. So we see a lot more patients in our facilities that now have access to care, who have insurance, recognize they can get regular care on a regular basis.
And on a very practical basis, yeah. Two things. One, does that mean the hospital or the physicians actually get paid on a regular basis because people have the ability to get paid, to pay for services, so that's made a difference on your bottom line?
Well, it's really practical. So, obviously the reimbursements for Medicaid is anything but rich, but on the other hand, it's certainly more than having a large contingency of patients that have no ability to pay. So we've seen a substantial decrease in the number of patients coming to our facility that are unable to pay at all. So the uninsured population to us has dropped about 7%. So it's had a tangible impact.
7%, mm-hmm. So that's marginal but significant.
Significant, but to individuals, it's enormous. So you see people coming into the facility who have chronic diseases, who really haven't accessed care in the past, who now have confidence that they can get the continuum care, not just the acute hospital care, but they can get care after they leave the hospital. Okay. And it's really made a tangible difference.
Craig, from your point of view, looking over the entire greater Cincinnati market, because it's not just one system. Sure. Do you see sort of the same thing? Because you would also be looking at Northern Kentucky, where sure. The exchanges were, the exchange in Kentucky was run very well, mm-hmm. but I'm not sure that was Medicaid expanded in the same way that it was in Ohio?
Mm-hmm.
It
right.
was?
And so, what Rick said is true for UC Health is certainly true for all the health systems and even independent physician groups and smaller provider organizations. You know, it's just a simple question of, do we want to provide coverage for this segment of the population? And with Governor Kasich's leadership and taking advantage of opportunities from DC, we've been able to do that in Ohio. And by the way, this links to things like the United Way's bold goals, which is one of their measures is consistent access to health care, one of their core measures, and that's definitely influenced by this.
Well, and I think that your organization is very clear, and not that yours isn't, but it's about keeping people healthy, not
Sure.
just sick care.
That's right.
And the Affordable Care Act had put a big emphasis on that.
True.
You're an IT data person. Do you think we can measure that? Is it making a difference?
Absolutely. We do a lot of measurement.
I know you do.
Anything that we do, it's a lot of data work.
And that's your background. You
Yep,
love it.
Right, true. One of the things I'm really excited about Greater Cincinnati, about our partnership with all the health systems in this region and now beyond across the state of Ohio, this community, believe it or not, is leading one of the largest outpatient payment demonstrations in the country. And it's a simple concept that is reimburse primary care doctors for keeping people healthy and out of the hospital. Simple concept, but heretofore, the way the economics of the health sector worked, physicians weren't rewarded or weren't even supported financially for doing things to help prevent hospitalization. And now they are. So this is now scaled across the state of Ohio. All the major health insurance companies are involved, including Medicare and Medicaid, and all the major health systems in this region. So actual patients will see a result on things like maybe your doctor will say, hey, you don't really need to come in for that. We could do this over the phone. Whereas in the past, it's always come in, sit in the waiting room. They could say, hey, you just got discharged from the hospital. We learned about that kind of electronically. We were notified, and we just wanted to check on you, see how you're doing.
Again, that was one of these situations where built into the act was caregivers, hospitals had a real responsibility to make sure people did what they were supposed to do when they left, and so they didn't end up back in the hospital within 30 days.
Absolutely.
Because you would get penalized.
You know, I think that Craig brings up a very important point. As part of the act, actually stimulated creative thinking and innovative ways of providing care. And under Craig's leadership and the collaborative has made a real impact on redesigning primary care in a way that really allowed them the resources to not just channel patients through one after the other, but really think about how they can take care of and understand the patient's needs in the full context. They had the resources to really take care of the patient and its total needs.
Well, let me shift a little bit. What would have, American Health Care Act didn't go through, but they're going to keep working on this. But let's take that just as the model for the moment. What measurable impact would have had on your system if that had gone through?
You know, I think there are two things as is being discussed that was of concern. One is that there was going to be some degree of people losing access to care and insurance. I don't think it was clear how much, but there's clearly a concern that a vulnerable part of the population would no longer have access. I think the other concern they have is really its impact on the insurance market, the volatility. In fact, trying to understand and trying to prepare for a market that's so volatile actually becomes difficult when you're leading a large organization.
Yeah. Craig, what do you think? Anything that you were particularly concerned about as this was moving forward?
Well,
or particularly encouraged by?
Sure. Well, the good news is that despite all the rancor and the talking heads, there is fundamental agreement on some core principles across the political spectrum. Those include we need to wire to the health sector, we need to help it catch up from a technology perspective with the rest of the economy, and we need to rethink the way we pay for health care. And so that has strong bipartisan support, but many of us were involved over the past several months in making sure that those elements of the Affordable Care Act were maintained and in whatever came down the pipe.
How we pay for health care. What do you mean by that specifically?
Well, what we talked about a minute ago is an example of a new way to pay for health care. Traditionally, we paid for volume and intensity. So if you're in the health sector, the way that you win that game is by doing more and doing more fancy stuff. You don't win by taking care of people and avoiding hospitalizations. Okay. And so fundamentally just shifting the incentives to paying more for outcomes has strong bipartisan support.
The other part I'd add is that there's this fundamental tension that I think there is great support that people should have access to quality care. But the issue is how we're actually going to pay for it. And that's the yin and the yang that we have bouncing back and forth. And so at the core of this is how do we actually make healthcare affordable? How do we put the right stimulus in to make sure that we're living into our responsibility to make sure that people have access to high quality care that actually is sustainable and affordable.
And Rick makes a good point there with, it's not about affordable insurance coverage. Ultimately, it's the cost of healthcare is driving why people are uninsured or have access problems. So, at the core, it's about being more efficient as a society.
I want to play one more little soundbite and then have you react to this. Let's listen to the President of the United States.
I've been saying for the last year and a half that the best thing we can do, politically speaking, is let Obamacare explode. It is exploding right now.
First off, I don't know if it's exploding or not, but we're now in this funny time in between. A new system wasn't adopted. The health insurance companies, I'm sure, were trying to say, well, how are they going to adjust? You all were saying, how are our systems going to adjust? And now we're sort of in this in-between state. Will things just sort of unravel at this point?
I think that the part of the plan, of the components of the ACA that has been the most challenging, I think, has been the exchanges. It's been challenging from everybody's perspective. It's been challenging for the payers. It's been challenging for the patients themselves. And I do think there's going to be a lot of movement in the market one way or the other to figure out how to make that more effective. And I do think regardless of what happened, that was going to be a key issue moving forward.
Okay.
Dan, we don't have a healthcare system. We have a healthcare situation. It's a challenge for everybody in the country to kind of sort this through. And I'm particularly concerned just in this era of uncertainty that you're alluding to and you set up here, that leaders like Rick and his peers across America, they don't have clear enough signal strength yet, signal on what the future is going to look like. And that's very, very difficult for them to run institutions like that.
The one thing that I haven't heard a lot in the debate that's occurred that does concern me is the other thing that's emerged in these insurance plans are these high deductible plans. And so people are not really buying access to health care, they're really buying catastrophic insurance. And so if you're making a reasonable income of $40,000, $50,000 and have 3 kids, and you have a deductible of $5,000, you're really no closer to healthcare than you were when you're underinsured. And so one of the things that I've been concerned about, the trends, it was true on both of the proposals, is really this emergence of high deductible plans. And we're seeing that starting to play out where people are delaying care and really trying to figure out how they maximize, or really whether or not they have $4,000 if an event were to occur.
As someone who was self-employed for 19 years and out on the market myself, you get those high deductibles and you find out just about the time you get to the point where you might actually get to use it, January 1 comes and you start all over again. I think everybody should, who gets it through their companies should understand that there's a lot of people out there in these high deductible plans, which may sound just fine, that are really difficult to make it work. And it's high deductible on every member of the family.
So we still have work to do to make sure that we get to, I think, this bipartisan goal that people have access to quality care. It's really figuring out how we're going to be able to afford it. And I think part of that's incumbent upon the industry itself to figure out how do we make health care more affordable? How do we get these great outcomes but do it more effectively, more efficiently?
One of the real practical things that was talked about as we were going into the ACA was changing the way people misused or misused emergency rooms. First off, because they didn't have a medical home, they just went to the emergency room and got basic care there. Has that changed? Can you measure it? Has there been an impact on the way that people are actually using emergency rooms?
Well, we have some local data, and I'll let my data colleague here answer that in a moment. But You know, I think that we have still seen issues in our community where we actually have primary care deserts. We talk about food deserts, but we also have parts in our community that even with insurance, they don't have access to primary care. And so one of the things that we're working on is working with communities to identify those areas where there's not primary care.
What would you point out in our community as a
So one of the areas we're working right now and working with the city and the county is actually in Avondale. So if you look in the city of Avondale, there's really not a primary care provider in that community
which
right
is
now.
ironic since it sits
At the
right
foot of-
next
exactly.
to or part of
So part of our initiative is
Hill.
to get off the hill and into the community and really provide that access. So without those points of access in the community, you're still going to say, I'm sick, where do I go? So they're still seeing some inappropriate use, but we actually have seen a measurable decrease. But you have probably citywide data.
Citywide or even nationally,
Yeah.
the short answer is no. It hasn't decreased to the extent that was hoped for. The longer answer is that as some of these payment initiatives that we've discussed are coming into play, we're seeing significant reduction, not only emergency use, but other high cost. For example, this demonstration I talked about, over 3 years, there was a 23% reduction in avoidable hospitalizations. Those are folks who really didn't need to be in the hospital if they were better taken care of on the outpatient side. And the same is true for emergency.
and that's measurable.
That's those are real numbers.
I'm just about out of time, but are you, the two of you, others who are in your field, are you talking directly to our representatives, both in the House and the Senate? Do you get to talk to Steve Shabbat? Do you get to talk to Dr. Brad Wenstrup about your observations on this? Is this a conversation that's going on? Do you have input?
So I'll speak, I'm working with a number of associations, including the Ohio Hospital Association. We were actually in Washington the day the bill was first announced and revealed, had an opportunity to speak with Senator Portman, Representatives T. Berries, and several congressmen in Ohio. And really, this dialogue about the tension of really wanting to make sure that people have access to affordable health care, but in fact, how do we make it affordable, was really at the tip of the discussion. So yes, we've had access. They've asked our input. People really want to deal with this effectively.
You too?
True. I was up there a couple weeks ago, and we have a fantastic delegation here. Dr. Wenstrup in particular is terrific as a clinician, of course, and passionate leader. At the end of the day, though, all healthcare is local, and so that's kind of where my passion lies. It's really about local leadership.
And that's why I keep coming back to this these last 3 weeks.
Yeah.
No matter what's going on in Washington,
That's right.
healthcare is local,
You got it.
as are many things.
We have to take care of our neighbors.
Thank you very much for being here. Good luck as we work our way, we all work our way through this in the future. Stay tuned. After the break, the leader of a new initiative to create a museum focused on the stories of millions of people who have lived in Over the Rhine in the last 180 years. Over the Rhine, Cincinnati's port of entry neighborhood for international and domestic immigrants for 180 years, is famous for its concentration of Italianate and Victorian architecture. In the last 12 years, OTR has been transformed into a trendy urban walking community, attracting young professionals and empty nesters to live in its redeveloped condos and suburbanites to visit in the proliferating bars and restaurants in the evenings and on weekends. Welcome back. For the past 2 years, a group of people have been working to develop an Over the Rhine museum. The mission is to tell the stories of the Over the Rhine using his historic tenement. A model is the Lower East Side Tenement Museum in New York City, which I consider personally one of the 5 most important history museums in the United States. If you haven't been there, go, and then go to the one when it opens here. The goal for the OTR Museum is to explore all aspects of the district's history, including the early settlement, German history, other immigrant groups, Appalachian migrants, and African American residents. I am joined now by Delano Steinert, an urban historian and preservationist whose work focuses on using the built environment to tell stories of the past. She is a co-founder and board chair of the Over the Rhine Museum, an organization that seeks to collect, preserve, and present the stories of the district. Anne, welcome to Newsmakers.
Hi, thanks for having me.
Okay, so why a museum? Why not do this as a series of programs or part of another institution?
Well, I think the thing that's going to be really unique about the Over the Rhine Museum is that it's going to be an immersive experience. So what we're going to do is take a historic tenement building with, let's say, 4 different apartments.
And I'm going to stop you, by the way. There are people who think Cincinnati tenements are significant in themselves and a little bit slightly different variation of what's in New York. So just as a throwaway, go ahead.
Do you want me to talk about that?
No,
because
no,
I'm one
I don't.
Of those
I don't
people.
want you to get caught in the corners.
Okay, all right. So we're going to take a tenement building, let's say it has 4 units, and each unit would then be interpreted to a different moment in the past of the neighborhood. So we'll research the people who actually lived in that building, and we'll tell their story as best we can.
Similar to what the Lower East Side Tenement Museum.
Exactly. So one apartment might be 1870, one might be 1900, one might be 1950, one might be 1990. We're really committed to telling the whole history of Over the Rhine up into the recent past. The one thing that makes us different about other than the Tenement Museum, though, is that their interpretation stops in the late 1920s when their building became vacant.
Shut down.
So we'll be able to tell those much more recent stories, which we're really excited
Simply
about.
because the buildings here
are inhabited
and in use.
Right.
So, you know, so often people think, and I use the term preservationist, and we talked about the architecture, and that's what people pay attention to. But it's really the people stories. Is that what you're really interested in?
Well, yes, both things. So
Okay.
I think that people live within a space, and that space dictates the way they can live their lives. So there's a give and take between lived experience and physical space, going both ways back and forth. So I think it's 2 parts of the same puzzle.
You know, one of the things, though, in the materials you sent to me ahead of time, you referred at one point in that material to the neighborhood. And I took that out. I used the word district because I don't think Over the Rhine was ever meant to be a neighborhood as we understand neighborhood in the modern city. And the dynamics are really quite different. The variety of people who live side by side, the variety of functions that were going on side by side. These are not the sort of neighborhoods where I define neighborhoods as I live in a place that everybody's just like me.
Oh, interesting.
Yeah, so
I sometimes say that Over the Rhine was settled as a German enclave where people could live and work, go to school, go to church, do their shopping, all within that contained space. So there was industry, there were shops that often had the apartment units above, so people could really live their whole lives in that contained space.
Have you identified a particular building that you want to focus on, and can you even identify it here?
Yeah, so we've looked at about 25 different buildings as possible sites, and we're really narrowing in. So we have about 2 or 3 favorites, but we're still continuing to look. We're not positive that we found our perfect dream location yet.
Okay, and in the meantime, you're doing programming,
right,
even though you don't yet have your building.
Exactly. So we really have 3 big programming components right now. One is that we have an exhibit called Stories of Over the Rhine, which are portable panels that we take out into the community. They were at the Downtown Public Library for about a month in the winter. We take them to all kinds of events. We're currently working on developing school programs so that we can take them into schools as well. And they focus on telling 12 different stories focused on a particular person in a particular place in Over the Rhine, but also helping us tell a bigger national story about the way Over the Rhine fits into a national context. Okay. So that's one thing. The second is that we have an oral history project going where we're interviewing people who have history in the neighborhood, either longtime residents, people who work there, people who came to worship or even for fun. And so we're trying to collect those stories so that we'll be able to use them as in our interpretation of the museum space, but also just to be able to disseminate them out and share that information. And then the third thing that we're doing is totally blanking in my head right now. So let's.
So you do these public programs
Yeah.
of a lot of.
Oh, there we
different
go.
variety.
The third thing is thank you.
The 3 speeches
that we have. That's right. That we have this lecture series called 3 Acts of Over the Rhine, which has been incredibly successful. So the idea is that we have 3 short talks, about 15 minutes, on disparate topics, and then they take questions all together. So we're telling 3 really different stories about Over the Rhine.
And you've got one of those coming up with a twist on it, which is also your first fundraiser. I want to make sure people know about
That's right.
this. So on Wednesday, April the 19th, The museum is hosting its first fun and fundraiser. The evening program will feature performances by Katie Lauer, oh boy, and Ma Crow, Molly Sullivan, Jake Speed, and the Freddies. Advance tickets are only $10 and can be purchased online at cincyticket.com or woodwardtheater.com. This is going to take place at the Woodward Theater in Over the Rhine. And tickets at the door that night are $12. Thank you for being here. We're going to follow this story as this whole museum to start. I got
Thanks
a lot of
for having
ideas to talk to you about. Thank you for making Newsmakers a part of your Sunday morning. Join us again next Sunday as we meet the men and the women working to make our region a better place to live in the future. Have a good week.
Thanks.